Good night, everyone. So today I'll be presenting on the management of craniopharyngiomas. Firstly, this is a benign tumor, WHO grade 1, and it doesn't metastasize. So it doesn't transform into something malignant. And yet, Harvey Cushing, who is the father of neurosurgery, called it the most formidable intracranial tumor back in 1932. And nearly a century later, the description still holds up. So what makes craniopharyngiomas so challenging is not only it doesn't make us answer the question of can we remove this tumor, but what kind of life will this patient have afterwards? So here's the presentation outline. We'll start with what the tumor is, where it comes from, epidemiology, clinical features, diagnostic criteria, histological subtypes, imaging, treatment, and we'll spend a good amount of our time on the surgical detail, post-op care, and finally the prognosis. So we have a lot of ground to cover. So what are craniopharyngiomas? So they arise from the remnants of Rathke's pouch, which is a small piece of tissue left behind when the pituitary gland itself was developing in the embryo. Normally, those remnant cells disappear completely, but in craniopharyngiomas, they don't. And they form a tumor right at the base of the brain. So WHO grade 1, histologically benign, but benign on the pathology report doesn't usually mean, in this case, doesn't mean benign in behavior. It goes right next to the optic chiasm, the hypothalamus, the pituitary stalk, and the major vessels at the base of the brain. And we can't just simply cut around it. So the important thing to understand for us is that for many patients, it's not the tumor itself that destroys their quality of life, but the damage caused by trying to remove it. And studies have shown that craniopharyngioma survivors have some of the worst quality of life scores of any brain tumors, worse than many malignant tumors, despite it having good survival rates. And patients can be technically cured and still have diminished life. And that is what drives the management decision in this disease. So in craniopharyngiomas, we have a bimodal age distribution, children between 5 and 14, and then adults between 50 and 75. So about 0.8% of all brain tumors overall is what it constitutes. But in children, it is the most common non-neuroepithelial brain tumor. So it is something that you will see. And the two main subtypes map differently onto these age groups. So the first one is adamantinomatous, and it affects both of the peaks, and papillary is almost exclusively an adult tumor. And as you will see, the subtype matters just beyond the histology, different molecular drivers, different imaging characteristics, and different treatment options. We now recognize it as two distinct diseases that happen to occur in the same location. So the clinical picture is a story of compression. So wherever the tumor is pressing, that's what symptoms you will see. And most patients have a combination of several of these by the time they are fully diagnosed because these tumors grow very slowly. So the first one, pituitary compression, causes hypopituitarism. So in children, this often presents as growth failure or delayed puberty, subtle symptoms that get missed for months. And in adults, you see like more insidious symptoms, so like fatigue, weight changes, reduced libido. In terms of optic chiasm compression, this gives the classic bitemporal hemianopia. So you have loss of the outer visual fields in both eyes. And patients notice that they bump into things on the sides and the central vision is preserved. So a lot of the patients don't typically notice until the disease is quite advanced. Right? Hypothalamic compression causes hyperphagia and obesity. I'll come back to this a little bit later in more detail when I talk about some of the complications. But very briefly, it's not ordinary weight gain. Basically, the satiety center is damaged and patients literally cannot feel full. Stalk compression causes disconnection hyperprolactinemia. So the dopamine can't get down to the pituitary and the prolactin rises, causing galactorrhea and amenorrhea in women. And large tumors obstructing the CSF flow cause obstructive hydrocephalus. So you get headaches, vomiting, papilledema. This is often the acute presentation that brings a lot of the patients to the hospital. So diagnostic criteria. So both subtypes share one thing in common, one fundamental thing in common. They are both tumors of the cellular and the supracellular region. So that's the starting point for both of them. And that's the essential first criteria for both adamantinomatous and papillary craniopharyngiomas, right? A tumor in the cellular region. And that's typically where the similarities tend to end. After that, things diverge. So for adamantinomatous craniopharyngioma, on top of it being a cellular tumor, you need to see squamous, non-keratinizing epithelium that is benign, and a stellate reticulum and or wet keratin. And those last two, which is the stellate reticulum and the wet keratin, are the histological fingerprints for adamantinomatous craniopharyngiomas. So you won't see them in other tumors. For papillary craniopharyngiomas, which is also a cellular tumor, but the essential second criteria is different. You need non-keratinizing mature squamous epithelium covering fibrovascular cores or a cyst wall. So clean squamous cells, no wet keratin, no stellate reticulum, completely different architecture, right? So at the essential level, basically, they live in the same neighborhood, but they live in completely different houses. And then below that, we have the desirable criteria. So these are the molecular markers that confirm and strengthen the diagnosis, right? For adamantinomatous craniopharyngiomas, you want to see no nuclear beta-catenin immunoreactivity and a CTNNB1 mutation. And for papillary craniopharyngiomas, you want a BRAF V600E. And both the immunoreactivity and the actual mutation have to be confirmed. And importantly, for papillary, you want the absence of the beta-catenin and the CTNNB1, because having those would basically point you back to adamantinomatous. So the desirable criteria here in these cases are like the fingerprints. So you have the essential criteria leading you to what the suspect is, and then the desirable criteria confirm the identity of what exactly we're dealing with. Histological subtypes. So I had to, for me to understand it, kind of break it down in more plain language for me to understand the wording and everything. But starting with adamantinomatous craniopharyngiomas, the mutation is in a gene called, as I said before, CTNNB1. And all that gene does is produce a protein called beta-catenin. And beta-catenin is normally a messenger. So it carries signals inside the cells telling them when to grow, when to stop. And in normal tissue, the beta-catenin does its job and then everything gets destroyed. And then it gets destroyed. Now, in adamantinomatous craniopharyngiomas, the CTNNB1 mutation breaks the off switch. So the beta-catenin piles up inside the cell nucleus and keeps sending growth signals constantly. And the cells don't stop growing. That's the WNT pathway. And right now, there's no approved drug that targets it in craniopharyngiomas. And the research is still ongoing in that instance. Now, for papillary craniopharyngiomas, the mutation is the BRAF V600E, right? Is a different gene and it produces a protein that is part of the signaling chain called the MAPK pathway. So the signal passes basically, to understand it, from one runner to the next, and it ends with the instruction to grow. Now, the BRAF V600E is a mutation where the signal just never stops. So it gets a permanent grow instruction. But what is maybe exciting here is that this BRAF V600E is the exact same mutation, is the same mutation that is found in a significant proportion of melanomas. And because of existing melanoma research, they already have drugs that target this mutation. So, like dabrafenib blocks the mutated BRAF protein, and trametinib blocks the next runner in the chain, MEK. And together, these they interrupt the permanent growth signal that we have in the mutation. And early case series in papillary craniopharyngiomas are showing really good responses. So we have tumor shrinkages of about 80% or more in some patients, and some groups are now using it even before the surgery to shrink the tumor um, and reduce its adhesion to the hypothalamus, and thus making the operation more safer. So the possibility of eventually treating papillary craniopharyngioma without surgery in selected patients, of course, is being explored. We're not there yet, but that's the direction that they headed in. So histologically, the two subtypes look completely different under the microscope and even to the naked eye. So the adamantinomatous craniopharyngioma produces a dark, viscous, like oily fluid in the cyst, and surgeons like to call it motor oil. It's full of cholesterol crystals, and the fluid is chemically irritating to brain tissue. So if it's spilled during surgery, it causes chemical meningitis, and under the microscope, you see stellate reticulum and the wet keratin nodules and calcifications in up to 90% of cases, um, visible on CT as well. And papillary craniopharyngiomas look completely different than that. As we can see, the comparison side by side here is usually more solid, clean squamous epithelium, no wet keratin, no stellate reticulum, and very rare to see calcifications. Okay, so here we have diagnosis and imaging. So for the imaging, one rule to remember is the 90% rule for adamantinomatous craniopharyngiomas. So 90% show at least two of the three of these three features. One, cyst formation, calcification, and contrast enhancement. So supracellular cystic. So if you see a supracellular cystic calcified enhancing mass in a child, is a craniopharyngioma until proven otherwise. So CT is important. If we keep going, right, good. So CTs are important, is the best modality for calcification. So let's play it again. Right? For calcification, it has bright white, it's pathognomonic in the right clinical context. Here we can see the calcification ring coming up there. A lot of places go straight to the MRI and miss the CT. And also here we have the MRI giving us the full picture, tumor extent, hypothalamic involvement, stalk involvement, hydrocephalus. So here we have the tumor showing up there. On T1, the cystic component is often hyperintense, so that bright signal in the supracellular cyst is characteristic for craniopharyngiomas, and solid areas enhanced with the contrast gadolinium. So the papillary craniopharyngiomas look different on imaging than the adamantinomatous. It's more solid, less cystic, calcifications rare, often in the floor of the third ventricle, and the pituitary stalk is frequently thickened. So differential diagnosis for supercellular mass is very broad. I won't go through all of these in detail, but I wanted to flag two important ones. Number one, germinoma, because it is completely treated differently, not treated with surgery, chemotherapy, and radiotherapy. So we differentiated importantly to avoid unnecessary surgery in patients, and also Rathke-Cliff cyst is another common mimic as well. So it's a simple cyst, no solid component, no calcification, no enhancement, and is usually very distinguishable on imaging, but we'll keep it in mind as well. Others include pituitary adenomas, meningiomas, optic gliomas, hypothalamic hamartomas, germ cell tumors. And the key message from this is We have to build the full picture from age, clinical features, hormone profile, and imaging before committing to surgery, of course. So treatment overview. There are three pillars, as we can see here: surgery, radiotherapy, and medical management. The surgical approach has changed dramatically over the years. So early surgeons went for gross total resection. Take it all out and you cure the patient. Surgical mortality was over 40% in some cases. Um, Even as this tend to improve, the outcomes have remained poor. Not because the tumors recur, but as I said before, because survivors had devastating hypothalamic damage. And surgeons were essentially winning the operation but losing the patient. But the field had learned from this problem, and the current approach is conservative subtotal resection. So you take out what is safe and you leave what is stuck to the hypothalamus. And then you follow it up with adjuvant radiotherapy. So that combination would give a 5-year progression free survival of over 90% with far better outcomes than functional outcomes than previous measure. On radiotherapy, conventional fractionated um, radiotherapy at 50 to 54 gray standard, gamma knife could be used for small residual tumors. Protein beam therapy is increasingly used, especially in children, because it reduces the dose to the surrounding brain. And this brings me to the dilemma between pediatric versus adult cases because the approach differs by age. So in children, adjuvant radiotherapy is controversial because the developing brain is so sensitive. The radiotherapy tends to cause cognitive decline, IQ reduction, and it compounds the existing endocrine problems that the patients already have. So in children, many centers tend to defer the radiotherapy and accept a higher recurrence risk. And they would reoperate if it's needed rather than irradiate a young brain. So in adults, you could give the radiotherapy more freely, because but there's no universal consensus in this. The debate is still out and it's still decided on a case by case basis, like in an MDT or something like that. So on the medical side, the BRAF slash MEK inhibitors that I was talking about before for papillary craniopharyngiomas, which is the dabrafenib and the trametinib. So as I said, we have dramatic tumor responses in early case series that they're working on right now. Is being explored as neoadjuvant therapy to shrink the tumors before surgery. And this is the basically the future that papillary craniopharyngiomas management is heading. Okay, so now into more detail now. Pre-operatively is really important for the management of this patient. So of course we need full endocrine workup. So the cortisol is urgent. Hypoadrenalism under the stress of surgery means adrenal crisis. So cardiovascular collapse, preventable death, give hydrocortisone. The thyroid deficiency also increases surgical mortality, but it takes longer to correct safely. So we have to really balance the timing of when we're taking the patient to surgery and all of that to make sure we correct all of these problems. Of course, you must do the baseline visual fields and MRI for surgical planning. So the approach depends on the location of the tumor. So most common is a large right frontotemporal craniotomy. Also, we do endoscopic transsphenoidal is being used more, so you don't have to retract the brain, and it's good for centrally placed tumors. Transcolossal is strictly used for third ventricle tumors. So four important pearls I'd want to mention is first, always aspirate the cyst, deflate it first, and create space to work. So every tumor should get aspirated is the consensus. Secondly, protect the arteries on the undersurface, below the optic chiasm, because that is his entire blood supply. And if we cut them, the patient will wake up blind. Thirdly, preserve the pituitary stalk. So if you can see, like on the when you look through the microscope, you see the longitudinal striae, those would be the portal veins. And That's the highway basically between the hypothalamus and the pituitary. So that tissue would still be alive, so we have to leave it, even a remnant of it. Number four, if the tumor won't come off the hypothalamus cleanly, we have to leave that as well. Don't pull and avoid excessive retraction. The hypothalamus doesn't regenerate, and leaving a adherent portion and let radiotherapy basically handle clearing out the rest of it. So the Ommaya reservoir is a good solution for cystic craniopharyngiomas, especially ones that tend to recur. So a small um, reservoir is implanted under the scalp, connected to a catheter into the tumor cyst, and it allows repeated aspiration of the fluid without going back to theater. And also, you could also deliver chemotherapy through it, intracystic, bleomycin, for example. So, for patients who've had surgery and radiotherapy and are left with a recurrent cystic component, it is often very practical and a long-term management tool to include the reservoir there. Minimally invasive, repeatable, and it keeps the patient out of the operating room. Contrast is better to use than a VP shunt because of the consistency of the fluid. It will be too thick due to the cholesterol-like nature of the fluid to use the VP shunt. So post-op, steroids, we tend to get steroids immediately. So hydrocortisone and dexamethasone for the edema, you taper it slowly, and because rapid taper increases the risk for chemical meningitis, as I was mentioning before, from the residual cyst component. And we have to monitor the sodium very closely from the moment they leave theater. Um, so post-op management and complications. Post-operatively, the complications tend to fall into four main categories. So the first one is diabetes insipidus. So this has already been covered in detail in previous presentations. I won't go too much into it, but key point is that it's very common post-op and follows a triphasic pattern in many patients, and sodium monitoring is very critical. So the danger is phase two, which is the SIDH phase, where when we give desmopressin on top of the natural ADH surge, it can cause severe hyponatremia, which is what I was saying, but to check the sodium before every dose and monitor the sodium for a while post-op. So next one, endocrine deficiencies. So pan-hypopituitarism is very common after gross total resection. So we replace the cortisol first, always before the thyroid hormone, because starting levothyroxine in someone with unrecognized adrenal insufficiency can tend to precipitate a crisis. So then we do the thyroid, sex hormones, growth hormones, and patient has to be on lifelong endocrine follow-up. So hypothalamic obesity now. So this is where I want to spend a little bit of time because I was mentioning it before. Is a very devastating long-term complication. So the ventromedial hypothalamus is the satiety center. So if it is damaged, if by the tumor or the surgery, basically the patient cannot feel full. They eat constantly, severe rapid weight gain, metabolic syndrome, heart disease, sleep apnea. So it's not ordinary obesity and it doesn't respond to ordinary measures. GLP-1 agonists are being trialed and they show good promise, but they don't have a solution yet for it. And this is one of the strongest arguments for hypothalamus sparing surgery in the first place. So we choose subtotal resection over gross total resection. Visual and neurological complications. So field defects may improve post-op as the compression is relieved, but any pre-existing optic atrophy is unlikely to recover. So you have to do serial visual fields. And as I mentioned before, in pre-op, we should have the visual fields test before, so we have a comparison to make to post-op visual fields. right? And aseptic chemical meningitis. So from a spilled cyst content, it presents like an infection, but is treated with steroids and not antibiotics. So prognosis and recurrence. So the survival statistics, it tends to look reassuring. So 90% at 10 years, over 90% 5-year progression-free survival with subtotal resection plus radiotherapy. But I want to just mention again the quality of life that I was speaking about a little bit in the beginning. The recurrence rate is very high. Most happen within the first year, um, and rarely you see most of them recur before 3 years. So reoperation carries a significantly higher morbidity and mortality on the first surgery because of scar tissue. You already have a traumatized brain, um, potentially already damaged hypothalamus. The second operation is basically always harder than the first. And beyond recurrence, we have to consider the burden of some of survivorship on some of these patients because they have to do lifelong hormone replacements, regular MRIs, and as I was saying, endocrine follow-up lifelong, ophthalmology. So they carry this diagnosis for a long time, decades. It's not just, let's cut out the tumor and you're okay. It's a lot of follow-up after. So some studies um, consistently show that craniopharyngioma survivors score worse than patients with malignant brain tumors in terms of quality of life. So that's to the extent of how devastating this tumor is. When a benign tumor produces a worse quality of life than some cancers. And that is as I was saying, is really show how formidable this disease is. And Cushing was right in 1932, and he's still right even today. So the factors most predicting poor outcome, as I said, are hypothalamic involvement and age. So children with hypothalamic damage fare the worst. Um, More aggressive resection does not mean better outcomes when you factor in functional status, which is the lesson that this disease has taught us. So the key take-home points, number one, it's benign on the report, but it is malignant in behavior, and the location of it is really everything. Number two, there are two distinct diseases. Previously, it was considered two subtypes of the same disease, but now we have two distinct diseases, adamantinomatous, which has the CTNNB1 mutation, and seen in children and adults, and you have papillary, which has the BRAF B600E mutation, and seen in adults, typically adults only. You have different molecular drivers and different treatments typically. Number three, compression syndrome. So based on its anatomy, where it's compressing, the chiasm, the optic chiasm, the hypothalamus, the stalk, foramina, there you get your symptoms. Number four, 90% imaging rule. So, and you have the CT to assess calcification and the MRI to assess the extent of the tumor, of course. Number five, conservative surgery plus radiotherapy. The hypothalamus matters more than complete resection, and pediatric management is a whole separate conversation. Number six, BRAF D600E is a targetable mutation, right? We have the dabrafenib and trametinib, and the future craniopharyngiomas is rapidly coming on board. And seven, there's good survival, but a complex or survivorship. So the quality of life basically paradox. And these patients would need lifelong multidisciplinary care. So to close, Cushing called this the most formidable intracranial tumor in 1932. And now the surgery is safer, the radiotherapy is more precise, and targeted therapy is on the horizon. But the challenge is removing a tumor from the most dangerous neighborhood in the brain without destroying the neighborhood. That's exactly what it was and what it is. So I'll stop there. Thank you very much for listening. Do you have any questions?